Hello everyone. Today I'm going to talk about the tubules and the interstitium. Prior to that, I'll just have, as usual, we'll have a recap of the disease yesterday. That is about the IgA nephropathy. That is a secondary glomerular diseases which are causing the uh, nephrotic syndrome. And also we'll talk about the chronic glomerular nephritis that we have seen. Okay, so let's start. So the overview of the yesterday's class, that is IgA nephropathy, the Henoch's colon purpura, which is of the same spectrum of the disease belonging to the IgA mesangial deposits, the lupus nephritis, the diabetes mellitus causing the diabetic nephropathy, cryoglobulinemia, fibrillary nephritis, hereditary diseases including the Alport's disease and also the thin basement membrane lesion, and also, as we have discussed yesterday, the chronic glomerular nephritis. Today's class, I will be discussing about acute tubular necrosis, acute interstitial nephritis, including the acute pyelonephritis, chronic pyelonephritis, drug-induced and analgesic nephropathy, urate nephropathy, lead poisoning causing the AIN, myeloma causing AIN, chronic renal failure, multisystemic disorder ending into the end-stage renal disease. Okay. So IgA nephropathy, I told you, is seen because of immunoglobulin A deposits which are getting deposited in the mesangium. Right? Age groups that are involved are usually the children and young adults, but it can be seen in other age groups also. So, how the IgA nephropathy is manifested is that the pathogenesis, now coming to the pathogenesis, the immunoglobulin A is usually present in the respiratory secretions and the gastrointestinal secretions. So, this person or the patient coming to you may give you prior history of any infection supposedly involving both this respiratory or the gastrointestinal tract, right? So, the immunoglobulin which is present in the plasma is usually in a monomeric form. Once it is going into a polymeric form, it is trying to be degraded by the liver. All these polymeric forms which are increased in number are getting degraded by the liver. So if there is an injury to the liver, what happens is that this degradation is not happening and thereby there is increase in the polymeric forms of the IgA or immunoglobulin A. And there is aberrant glycosylation of the immunoglobulin A. Okay, you know that immunoglobulin A is formed by the chains, right? So there is an abnormal glycosylation happening to one chain, so that there is an abnormal immunoglobulin A deposition. Okay, so because of this pathogenesis, there is increase in the immunoglobulin A that is getting deposited. So once this immunoglobulin A is getting deposited, either it will be depositing by itself or it will go and have some friend like immunoglobulin G, and then both of them get together and then they get deposited. Okay, because of that there is an immune complex formation and thereby there is a reaction causing recruitment of leukocytes, then the complement activation. So this is happening because it wants to get degraded. So especially the important point of IgA nephropathy is that absence of C1q and C4. Okay, this is happening because the complement is trying to degrade the immune complex or the injury caused by the immunoglobulin A or the immunoglobulin A and G together. Okay, thereby there is the destruction of the glomerulus causing the glomerular pathology. So thereby there is mesangial deposits which are taking place and they are trying to converge or destroying the glomerulus and the filtration will get affected. How does this IgA nephropathy present? See, once a patient has an IgA nephropathy, usually the patient will have a very slow progression. It is not very fast as in rapidly progressive glomerular nephritis or acute glomerular nephritis. It is taking some years for it to get into the end-stage renal disease. Usually it is mild to moderate proteinuria hematuria that is present, And then after prolonged years, maybe in the older age group, we will see heavy proteinuria, hematuria, and there may be casts which are seen in the urine microscopic examination. So this is about the IgA nephropathy. So just remember normal secretion of the IgA, usually in the monomeric form. If in the polymeric form, should be degraded by the liver. So if there is any problem to the liver, it will not destroy the polymeric form. Increase in the polymeric form happens, aberrant glycosylation happens. Then because of this, there is more increased IgA getting deposited into the mesangium. There is thereby inducing an immune reaction. Then there is recruitment of leukocytes, adding upon to the injury, and then the complement system getting activated to destroy these immune complexes and the mesangial deposits which are happening. So the main important point is absence of C1q and C4 is very crucial. And the other thing I'm going to tell you is that there is the progression of this disease is very slow. Okay, just remember all these points regarding IgA nephropathy. The other IgA nephropathy is the Henoch-Schönlein purpura. The Henoch-Schönlein purpura is again having the IgA deposits in the mesangium. But in addition to that, there will be vasculitis. Vasculitis can be seen in skin, gastrointestinal tract. So there will be usually the symptoms of vasculitis, that is the purpuric lesions on the extensor surfaces like the buttocks, legs and the feet. And then there can be abdominal pain and intestinal bleeding. And in addition to this, there can be joint inflammation and pain. So these are the characteristics of Henoch-Schönlein purpura. Usually 3 to 8-year-old children get affected, and then the progression is slow, like that of immunoglobulin A, IgA nephropathy. HSP is usually having an excellent prognosis. The child who is coming to you with suspicion, when you suspect this HSP, is that they will also give you a history of GI infection or a diarrhea prior to that, or a sore throat. Okay, this can lead us to some immune pathology. Okay, in the production of this kind of a disease and these kind of lesions. So again, you have to remember that HSP and IgA nephropathy come from a same ancestor of IgA deposits. So you have to remember IgA nephropathy not associated with vasculitis. Usually, I also told you there is primary and secondary. Primary IgA nephropathy related just to the kidney, and secondary related to the kidney after the damage of liver or something like gluten enteropathy. Remember, primary, secondary, and HSP, another disease of IgA in children 3 to 8-year-old with prior infective etiology. Then after removing or treating the etiology, it may get regressed, but you have to keep checking for the proteinuria and the hematuria in the child. Okay, usually it will come down and it will regress, but if it is not regressing, it may go into a very severe form of the disease also. Okay, this is about HSP. Now coming to another disease. See, now if you see, we are trying to discuss about all those diseases which are forming the secondary causes of the nephrotic syndrome or the glomerular pathology, right? So we have discussed about IgA and HSP leading to immunoglobulin A deposition. Now we are going to deal about lupus nephritis. You know that the systemic lupus erythematosus is an autoimmune disease wherein there is loss of self-tolerance and activation of the self-reactive T cells and B cells. Okay, so you do not want that to happen, but the self is trying to be manifested as an antigen itself, and then the antibody is produced, and then there is an antigen-antibody reaction, right? So in the lupus, after 5 years of the diagnosis of systemic lupus erythematosus, approximately lupus nephritis can be seen. If the SLE is not, it's progressing to a more serious form of injury or disease. So the WHO gives the classification of the lupus nephritis or the stages, wherein the class 1, the minimum mesangial glomerulonephritis, where you do not find any kind of pathology on the light microscopy. Then class 2, mesangial-proliferative lupus nephritis. Class 3, focal proliferative, focal, I told you, a fraction of glomeruli getting involved. Class 4, diffuse proliferative nephritis, wherein all of the renal parenchyma involved. Class 5, membranous nephritis, and class 6, advanced glomerular sclerosis. You have to be very confident about the SLE. When you are writing SLE also, you can just write about the classification of the lupus nephritis as an addition of that. So coming to the diabetic nephropathy. Diabetic nephropathy occurs after 15 to 20 years of the diagnosis of the diabetes. Prolonged hyperglycemia or uncontrolled sugars will damage the kidney as they form the advanced glycosation end products or AGEs. These end products are a result of the glucose attaching itself to the amino acids that are present on the tissue proteins. They get attached and then they get deposited on the basement membrane. What happens because of this is there is increase in glomerular filtration, hyperfiltration, then there is increase in the intraglomerular pressure, then there is the formation of all these things there in the renal parenchyma will cause oxidative stress, and this oxidative stress is causing the renal injury, which is progressing in the form of diabetic nephropathy as a glomerular lesion, a vascular lesion, or a pyelonephritis. Remember, the diabetic nephropathy can be explained under these three headings. The glomerular lesions can be bone, basement membrane thickening, diffuse mesangial sclerosis, nodular glomerular sclerosis or Kimmel-Steele-Wilson disease, fibrin caps, and capsular drops. Okay, all these 5 are important under the glomerular lesions. Okay, the vascular lesions include the renal atherosclerosis and the renal arteriosclerosis, which cause the hypertension. And hypertension again will have an effect on the renal parenchyma. Okay, and then the pyelonephritis is usually the papillary type of necrosis, what you see in the pyelonephritis and diabetic nephropathy. So, what are Kimmel-Steele-Wilson disease is? It is a form of collagenous deposition, which is PS positive material deposited in the form of nodules forming sclerotic lesions or extracellular matrix deposition. Because of that, what happens? There is again the glomerular filtration doesn't happen properly, right? So what are fibrin caps and capsular drops? I told you in the last class also. The capsular drops are the ones which are having the thing in the Bowman space, and the fibrin caps are related to the capillaries. This difference you have to know. And they are the non-collagenous substances which are getting deposited. If they are getting deposited beneath the Bowman space, it is capsular drops. If it is beneath the capillaries, it is fibrin caps, right? So renal atherosclerosis and pyelonephritis. Remember the AGEs formation, how they are formed, how they are causing the oxidative stress, the glomerular hyperfiltration, then the obliteration of the glomerular capillaries, increase in atherosclerosis or accelerated atherosclerosis, then the glomerular lesions, the vascular lesions, and the papillary type of pyelonephritis, which are classical of the pathological lesions that are seen in the diabetic nephropathy. So, after this, I will also tell you about some other lesions which we have seen yesterday, that is essential cryoglobulinemia. Essential cryoglobulinemia may be seen associated with some infections like hepatitis C. I am talking about essential cryoglobulinemia because we are speaking about the secondary cause of the glomerulonephritis causing the nephrotic syndrome. The secondary causes or the systemic causes. So what are they? We have spoken about IgA nephropathy, HSP, then we spoke about the diabetes, then the lupus nephritis. Now I'm talking about the essential cryoglobulinemia, right? The essential cryoglobulinemia is because of the deposition of IgG and IgM together. Okay, it is also associated with vasculitis and abdominal pain, and you can see some gastrointestinal disturbances in cryoglobulinemia. So remember this, okay, and then we have to know the other causes, that is fibrillary nephritis. So what is fibrillary nephritis is that it is abnormal accumulation of the chains, immunoglobulin chains, which are immunoglobulin G4 or immunoglobulin kappa, immunoglobulin lambda. They are different from the amyloid chains which are getting deposited because they are not stained by the Congo red, right? So again, when you get to know about the fibrillary type of nephritis, you have to get to know about the amyloid nephropathy again. Just to recap. Okay, the amyloid nephropathy, you know that it can be happening because of an amorphous eosinophilic extracellular substance that is getting accumulated in the glomerulus or the interstitium in the tubules that can give rise to amyloid kidney that is stained by Congo red. Okay, so this is about the amyloid. You have to differentiate between fibrillary nephritis and the amyloid kidney or amyloid nephropathy. Okay, then you just know that the bacterial endocarditis or any kind of infection can cause a secondary type of injury to the renal parenchyma because it can induce an immune complex deposition by antigen-antibody reaction. So just know these are the systemic diseases which are involved in the production of the disease to the renal parenchyma. Now coming to the hereditary diseases. Hereditary diseases, I told you, Alport's and thin basement membrane lesion. Alport syndrome is usually because of an abnormal formation of the collagen in the basement membrane. I told you the basement membrane is having the electron dense central layer formed by the non-collagenous domain 1 at the C-terminal and the helical molecule which is present in the center. Okay, this is the central dense area, and then there is in electron lucent area and the lamina externa, lamina interna. Remember this, they are formed by this basement membrane is formed by alpha 1 to alpha 6 chains, collagen chains. So any abnormality in alpha 3, 4, 5 chains will cause Alport syndrome. This collagen molecule or these collagen chains are also found in the eye and the cochlea of the ear. So whenever we are finding a patient coming to us with some abnormality pertaining to the kidney as a microscopic hematuria or mild proteinuria along with an eye deformity and hearing loss, we must suspect Alport syndrome in that. Usually, I told you that Alport syndrome is usually an X-linked disorder. X-linked disorder means the males are having just one X and the females two X's, right? Okay. So what happens in the males, as there is only one X, almost all the males get affected, and the females who are heterozygotes for this disease, that means only one X of the XX is infected. So because of that, there can be a manifestation in form of hematuria in females also. So remember that it is a hereditary disorder pertaining to what? Pertaining to the basement membrane, collagen fibers, alpha 3, 4, 5 chains, and then there is no proper basement membrane formation. So basement membrane, as you know, is important for the function of size dependent, charge dependent barrier in the glomerulus. That is not happening here. So because of that, there can be proteinuria and hematuria, right? So in addition to the collagen fibers in the renal parenchyma, there are these collagen fibers also in the eye and the cochlea of the external ear. So the patient will come with these three disorders. Okay, this is about Alport. So how do you find the microscopy? You find in the electron microscopy, you find this irregular basement membrane. Okay, that is classical of the Alport syndrome. So coming to the other hereditary disorder, that is thin basement membrane lesion. The thin basement membrane lesion is a defect happening again in the collagen. Okay, usually in the alpha 4 and alpha 5. So what is happening? Usually the basement membrane is of 300 to 500 nanometers thick, but here it is just 150 to 200 nanometer thick glomerular basement membrane that is formed. Okay, so there is a genetic defect here. So the filtration doesn't happen properly. So this is about the thin basement membrane lesion. Okay, in hereditary disorders, we're talking about Alport's and the thin basement membrane lesion. Thin basement membrane itself will give a clue to the thing what you have to talk in about the microscopy. So the basement membrane is thin here, 150 to 200 nanometers. Okay. Now, the chronic glomerular nephritis, I told you in the last class that chronic glomerular nephritis is not defined by a disease, but it is an entity which is a result of certain diseases which are present in the body, damaging the renal parenchyma for years together. It can be caused by membranous nephropathy, FSGS, MPGN1, MPGN2, okay. All these lesions, if they are not treated, the pathology is just continuing, the damage is just continuing, that will lead to an end stage disease called as chronic glomerular nephritis. Okay, even the crescentic glomerular nephritis or rapidly progressing glomerular nephritis can result in chronic glomerular nephritis if it is reversed, yet it is progressing in a chronic way. Okay, and post-infectious nephritis leading to the acute glomerular nephritis also very rarely can cause chronic glomerular nephritis, but usually it has become rare as we are treating the sore throat and all very well these days. Okay, so what do you find in the gross picture of the chronic glomerular nephritis is that the kidney is usually shrunken, the cortical surface is thinned. Then what you find is that there is obliteration of glomeruli because of scarring. The capillaries are occluded by the proteins which are getting insulated. Okay, and then there is hyalinization. Then there is inflammation which is occurring. So all these things will cause the chronic glomerular nephritis. In the microscopy, you find all these things along with the arteriosclerosis that is happening. So this picture I told you is Mason trichome strain, which is trying to give you the idea of the scarring of the glomeruli. So there are loss of the glomeruli. Okay. So this is about the chronic glomerular nephritis. So coming to today's topic is acute tubular necrosis. Acute tubular necrosis is an entity caused by damage to the tubular epithelial cells with acute decline in the renal function. Okay, so there is acute decline in the renal function because of what? Because of the tubular damage. So whenever there is a tubular damage, the tubular cells are getting detached and then they are thrown out. So these thrown out detached tubular cells are forming that CAS, the tubular CAS, and also whenever there is an injury, the WBC will come and try to fight the injury, so there will be granular CAS. So here, as a definition, there is damage to tubular cells, acute decline with shedding of granular CAS and tubular cells in the urine. So ATN is severe but is potentially reversible. Renal failure due to impairment of tubular epithelial function is caused by ischemia, toxic injury. Acute tubular necrosis, that is, the tubular damage is being caused by two things usually. One is either hypoperfusion or ischemia, or a direct toxin attacking the tubules. So it is an ischemic injury or a toxic injury. Because of this, what happens? Usually, see, necrosis is not often a prominent feature of the acute tubular necrosis. It is appropriate to call ATN as acute renal injury or ARI. So ARI and ATN are synonyms. So what is happening? The pathogenesis, either the toxic injury or the ischemia, what they cause is vasoconstriction of the afferent arterioles. So thereby there is a tubular injury. Whenever there is a vasoconstriction of the afferent arterioles and the vasodilators are not acting properly, so there is decreased GFR. So whenever there is an injury, what happens? There is inflammatory cells that try to combat the injury. So there is interstitial inflammation. The tubular injury, the tubular cells itself will get slugged and detached. They form the slugged cells. So, and because the tubular, you know that the proximal convoluted tubule, the loop of Henle, and all the collecting duct, everything are important for maintenance of electrolyte balance and acid-base balance and water reabsorption that is taking place, right? So whenever there is a tubular injury, there is tubular back leak, so that there is decreased urine output, that is oliguria. The slugged cells will cause obstruction, so all this will be contributing to the tubular injury and the pathogenesis regarding this. So the same thing depicted in the mirror. So there is afferent arteriole constriction. Okay, here. So what is happening? There is decreased GFR. Okay, there is no dilatating factor acting here. Initially, there is a tubular injury. The tubular cells will get slugged, and all the cells may obstruct the tubules, and then there can be a fluid escape into the interstitium here, and then as such there is no proper intraluminal pressure will get exaggerated or increased because of this obstruction. So there will be a back leak from the tubule. So this is the pathogenesis of the tubular injury that happens as a result of ARI. Okay, so what are the clinical manifestations? Decreased GFR, obviously, elevation of serum creatinine, oliguria. Oliguria, I told you how it is caused. Because of the backflow, there is no proper urine flow that is getting into the tubules. Causes. So, more than 10% of ICU patients may have acute tubular injury. 40% of the patients who are on the treatment by some drugs by the doctors itself. I'm not saying this. The textbook says that. And more than 50% of the patients who are having shock, that is hypoperfusion, that will cause ischemia. So there is arterial constriction, decreased GFR, same thing happening because of that. Then post-renal obstruction either by stone or BPH. Because of the obstruction, what happens? There is increased luminal pressure. Okay. Then because of that, the water may just backflow. Then there will be a tubular injury. The vascular causes like the hypertension, okay, rapidly progressing glomerular nephropathy and drugs, DIC, and urinary nephropathy are usually the causes. Okay. So what is the pathology? See, we have seen a common pathology of ischemic and toxic type of tubular injury, how they are causing the decreased urine output and how they are causing the decreased GFR. So now we will take individual one, that is the ischemic type. What is actually happening? Endothelial damage because there is no proper perfusion. So the endothelial get damaged, decreased vasodilator, increased vasoconstriction, vasodilators like nitric oxide, the prostaglandins are not working very well, and then increased vasoconstriction to the afferent arterioles, and they cause the decreased GFR. Now, what happens to tubule cells? The tubular cells, I told you, they get detached. There is obstruction. They form the tubular pigmented cast. There can be coagulative necrosis of this cast occurring. So, what is happening to the tubule cells? What is happening to endothelial cells? You have to know. Then sites where the ischemic damage is common: proximal tubule, medullary segment of thick ascending limb, tubular basement membrane. So, once there is CAS in the tubular cells, I told you there will be what? There will be increased intraluminal pressure. So, this will cause passive movement of the fluid from the tubules to the interstitium, and there will be backflow. Okay, this also you have to remember. Okay, so in the ischemic type, there is an endothelial damage. The tubular cells which are forming the cast, there can be coagulative necrosis, and then there can be backflow, increased intraluminal pressure, and then you are finding the sites. Where you will find the sites also, you have to remember that. Now, coming to the second type, the nephrotoxic type, the causes of the aminoglycosides, radiocontrast agents, and the heavy metals. What is happening? The proximal tubule is the one which is usually getting damaged. The tubular basement membrane is intact. See, here the difference lies. In the ischemic type, there is the basement membrane which is getting destroyed. So it can get interfered with the regeneration of the tubular cells. But in the nephrotoxic type, it is usually a direct injury by a drug or any metal, right? In the ischemic type, it is usually a pre-renal cause or a hypoperfusion. Okay, here in the nephrotoxic type, the tubular basement membrane is intact, so still the tubular cells can get regenerated. So, what are the clinical and laboratory findings of the acute kidney injury or the acute tubular necrosis? Are oliguria, obviously, tubular cas, hyperkalemia because the potassium is not getting balanced well, metabolic acidosis, increased blood urea nitrogen and creatinine, hypokalemia and infection. So all these things can happen. How they are happening is just remember the pathogenesis, you will be able to write all the clinical laboratory findings. So here we have the morphology, the microscopic picture. This is the H&D hepatoxymucin stain showing these are the tubules. You can see all these are the tubules. This is the detachment of the tubular cells into the lumen. Here you can see all the detached cells forming a cast. Okay, this is the protein that got insulated. So here also you are seeing the necrotic material. Okay, this is about the microscopic picture showing the acute kidney injury. So coming to the other one, we are finished with acute kidney injury, the two types, ischemic and the toxic type, and the pathogenesis and what are the clinical laboratory findings in the microscopy. Now coming to the tubulointerstitial nephritis, it is a group of inflammatory diseases that affect the interstitium and the tubules. If it is caused by the bacterial infection, it is called as pyelonephritis. Okay, so tubulointerstitial nephritis, nothing but the pyelonephritis. Okay. So this pyelonephritis can be acute or chronic, or pyelonephritis can be induced by a drug or analgesic or a urate crystals deposition or lead poisoning or myeloma. See, whatever it is, there is inflammation of the pyelo, that is the tubules and the interstitium. Okay, so whatever the reason is, it is causing the inflammation of the tubules and the interstitium, and we go one by one. Now we are going to talk about the acute pyelonephritis. So women are more affected than men. E. coli is usually a thing which is normally present as a commensal in the urethra. So if there is a back ascending infection, that it can cause acute pyelonephritis. Risk factors involving urinary catheter in patients, urinary tract obstruction, medullary sponge kidney, diabetes mellitus, pregnancy, sickle cell disease. All this can cause acute pyelonephritis. Okay. So, what is the pathogenesis of acute pyelonephritis? Usually, the distal part of the ureter in the bladder, it gets inserted at a level wherein there is, if there is an intraluminal pressure or whenever there is micturition happening, the distal part, that is the intravesical part of the ureter, gets compressed and it is closed. So the urine is not going back into the ureter. Okay, you understand what I am saying? The urinary bladder is filled. It is, you want to go and pee, then what happens? It is not going back into the ureter, but it is just stretching. Why is it not going back into the ureter and into the kidney is that the distal part of the ureter, where it is getting inserted in the urinary bladder, is usually compressed and closed during the micturition process whenever you are peeing, right? So whenever you are not, whenever there is a vesical reflex, what happens is that there is this closure that is not happening properly at the level of the ureter. So what happens usually, the short intravesical ureter, There is a backflow into the ureter and also into the kidney. What will happen to this reflexed urine? This reflexed urine, usually this part of the papillae which are present here, the renal papillae, the simple papillae usually convex, so they are trying to again throw out the urine. They are not going to encourage any sort of reflex. So there is this simple papillae will help us in protecting from an infection. The compound papillae which are there, they are concave, and then they are, because of the shape of that, there can be some infection that is happening here. So remember, the diseases which are causing the acute pyelonephritis is usually because of an ascending infection, okay, or a VUR or a hematogenous spread. So three things you have to remember. So here I have talked about the VUR, the vesicular reflex. Now I will be talking about the ascending infection. So lower upper UTI, the distal urethra normally colonized by E. coli. So whenever there is urethritis or cystitis, this infection, if the person is not immunocompetent and not treated well, the infection can pass into the ureter and then to the kidney. So there can be foci of pyelonephritis here. Okay, the hematogenous spread to kidney usually by Staph aureus, but usually this hematogenous type of acute pyelonephritis is usually rare. So ascending infection, VUR, and the foci of pyelonephritis because of hematogenous infection, like Staph, is the main pathogenesis in causing acute pyelonephritis. So the Bronson microscopy, here you can see the cortical areas which are thickened and maybe the potential areas of the abscess. Okay, so here you can see the congestion in between areas. There is some congestion. So there is areas of abscess formation in cortex medulla, the micro abscess formation. You can see the tubules are just infiltrated by most tubules and the interstitium studded with inflammation. Okay, this is the micro abscesses formation where you can see numerous neutrophil coming into action. Okay. So what are the clinical and lab findings? Piping fever, infection, obviously injury, there is pain, dysuria. Whenever you're vegetating, there can be pain. WBC CAS, obviously because there is inflammation. Pyuria, pus, hematuria, blood RBC or hemoglobin in the urine. So complications. Acute pyelonephritis can go into chronic pyelonephritis if untreated. There can be pelvic abscess in immunosuppression patients. Renal papillary necrosis can occur like that of the diabetes or a sickle cell anemia. Okay, and then septicemia and endotoxic shock can occur where you have to just give an IV antibiotics only, right? So we have finished about the acute pyelonephritis. Then coming to chronic pyelonephritis, the pathogenesis is vesicular reflex in young girls, lower UTI, as such the same as such of the acute type of pyelonephritis. See here, you will see the scarring of the cortical scars that are present because of the chronic pyelonephritis getting attacked here, usually in the upper pole and the lower pole. Okay. Because of this chronic pyelonephritis, usually it is associated with hydronephrosis because of an obstruction like stone or benign prostate hyperplasia, right? So whenever there is a stone or hyperplasia or obstructing, the lumen is getting obstructed, the pressure in the ureter will get increased. It's the same pathogenesis here. So coming to the morphology, there are two types usually, they say, according to the functioning, that is a reflex type of chronic pyelonephritis. They show the U-shaped cortical scars, the obstructive type wherein there is uniform dilatation of the calyces. Okay, the common point is the diffuse thinning of the cortical tissue. So U-shaped scars is the most important thing you have to remember, and dilatation of calyces that can happen and with thinning of the cortical tissue. Microscopy, you can remember it like this: glomeruli, tubules, interstitium, and arterioles are arteries, right? So the first one, glomeruli, there can be scarring, tubules, tubular atrophy and tubular thyroidization, interstitium, interstitial fibrosis and inflammatory cell infiltrate, arterioles, arteriosclerosis. Okay, so remember the things. What are in the renal parenchyma? Glomeruli, tubules, interstitium, and arterioles, right? So for glomeruli, you should say scarring, tubules, tubular atrophy and tubular thyroidization, interstitium, fibrosis, and inflammatory infiltrate. Then arterioles, arteriosclerosis. So the chronic inflammation is causing the scarring of the glomeruli, arteriosclerosis, I told you, tubular atrophy, tubular thyroidization. What do you mean by tubular thyroidization? Whenever there is a PS positive cast of the tubules that is getting deposited, they are the colloid cast as resembling the normal thyroid epithelium. Okay, whenever you see the thyroid cells in the middle, you find the colloid. Whenever it is getting secreted, a section of a normal thyroid, you see, you find the colloid. So in the same way here in the tubules, we see a PS positive cast known as the colloid cast, and the descriptive term here it is used is the tubular thyroidization. Okay. So interstitial fibrosis and inflammatory cell infiltrate, which include lymphocytes, plasma cells, and occasional neutrophils. Just remember the things which are there and what all you see. Okay. So here you can see the chronic pyelonephritic changes, the cortical scarring, okay, and congestion, lot of congestion here that is seen. And here in this hemisection, you can see the dilatation of the calyces, okay, and the thinned out cortex. In the microscopy, here you are seeing again numerous tubules showing the thyroidization changes. Here you are seeing the interstitium started with the lymphoplasmacytic infiltrate. Okay, so this is about the microscopy of chronic pyelonephritis. Coming to the drug-induced tubular interstitial nephritis, here the drugs usually that are causing the disease are the penicillamine, rifampin, sulfonamides, NSAIDs, and diuretics. Pathogenesis is usually type 1 and type 4 hypersensitivity, delayed and immediate hypersensitivity. Usually you take a drug after 2 weeks also the reaction may be seen. So within 2 weeks, if there is a reaction after starting a drug, then you can say that this drug has caused this reaction. So clinical and lab findings, there is fever, oliguria, rash. Lab findings, BUN creatinine ratio less than or equal to 15. I told you about in the first class when I'm talking about the blood urea nitrogen creatinine ratio, usually the normal value is 15. It is usually less than 15. Only if it is associated with renal parenchymal injury, when the skin and the gastrointestinal tract, they kind of take up the excretion duty. So the thing which is reaching the kidney itself is low, so we will find the blood urea nitrogen creatinine ratio less than or equal to 15, and there will be eosinophilia. Eosinophilia is a very, very major important point to diagnose drug-induced type of nephritis. So here you see the microscopic picture, you're finding a lot of eosinophils which are studded here along with the lymphocytes. See, these are the eosinophils, the bilobed ones, okay? And the pink eosinophilic or orangish cytoplasm, okay? This is giving you a clue towards the drug-induced type of the tubular interstitial nephropathy. So coming to the analgesic nephropathy, again, women more commonly affected than the men. Chronic users acetaminophen with aspirin more than 3 years. What acetaminophen causes is a free radical damage to the renal tubules in the medulla. And aspirin causes inhibition of the prostaglandin synthesis that will leave the angiotensin II unopposed and thereby decreasing the blood supply to the renal parenchyma. You know how the aspirin acts, right? So it is inhibiting the prostaglandin synthesis. It will leave the angiotensin II unopposed, so it is kind of causing less blood supply to the renal parenchyma. So free radical damage, inhibition of prostaglandin, decreased blood supply will lead to analgesic nephropathy. So what are the complications of this? Renal papillary necrosis that can be seen in the intravenous pyelogram, that can be forming the ring defect. It can be associated with hypertension in long term. It can also cause transitional cell carcinoma very rare. So coming to the other one, that is, so we have seen acute chronic nephropathy, then we have seen about drug-induced nephropathy, then analgesic nephropathy. Now we are going to say about the urate nephropathy. Deposition of urate crystals in the tubules and interstitium. Okay, this is happening because of massive release of purines. The purine metabolism is getting disturbed. So because of that, there will be deposition of urate crystals. This can be seen in lead poisoning and gout. What it can cause? It can cause acute renal failure. So coming to the other one, that is chronic lead poisoning. In chronic lead poisoning also, you will see the urate crystals. Okay, this is because the lead decreases the renal excretion of the uric acid. It has direct toxic effects producing the tubular interstitial tracts. So remember that the urate nephropathy can be as a result of abnormal purine metabolism, lead poisoning, or a myeloma also. Okay, so this urate nephropathy can also be caused sometimes by chemotherapy. Whenever we are using some drugs to treat the cancer, we can get this kind of a tubular interstitial nephritis. So myeloma. In myeloma, the disease is caused by these things. That is Benz-Jones proteinuria. You know that the protein chains getting accumulated, they form the tubular cast, then obliterate the tubules, thereby increasing the luminal pressure, backflow into the interstitium, and then there can be foreign body giant cell reaction that can cause renal failure. Nephrocalcinosis, see, there will be hypercalcemia. That is a very major picture that can be associated with myeloma. So because of this hypercalcemia, there are lytic lesions also in the bone. See, whenever you suspect a patient of a myeloma, then what do? You just do an X-ray, you find multiple lytic lesions, and you do a calcium, you get a hypercalcemia, then you know that you're finding the patient with the myeloma. Okay, how does this hypercalcemia result in? It will cause polyuria and renal failure. Okay, in myeloma, because of the abnormal protein that is getting accumulated, that will cause the primary amyloidosis. Okay, this myeloma thus will cause a tubular and interstitial injury. So, either the tubular disease or the glomerular disease finally are going to lead to something. That is the chronic kidney disease or chronic glomerular nephritis. I told you in the last class that either the post-infectious glomerular nephritis or eccentric glomerular nephritis or membranous minimal change, FSGS, membranoproliferative glomerular nephritis 1, type 2, whatever it is, if it is untreated or if it is progressing, its progression is going towards the chronic kidney disease with GFR getting decreased and eventually to an end stage renal disease where the GFR will get lower than 5%, right? So in the chronic disease, thus it is a broad term that describes the final common pathway of the progressive nephron loss resulting from the type of kidney disease. So the CKD can also result in the chronic renal failure. So what are the findings when you see a chronic renal failure are the clinical findings, anemia, because there is the kidney function is important for erythropoietin production, right? So erythropoietin is not being produced, so number of RBC getting produced is decreased, so thereby anemia. Platelet defects, usually in the form of qualitative type of platelet defects are seen that can be combated by dialysis. The third one is relating to the bone and calcium metabolism. Here we can see that there is renal osteodystrophy. This is because of there is osteitis fibrosis cystica relating to hypovitaminosis D. You know that vitamin D is metabolized in the kidney. Whenever there is decreased vitamin D, what happens? The vitamin D is essential for the absorption of the calcium from the intestine and mineralization of the bone. So this won't happen. So because of the hypovitaminosis D, this will lead to secondary hyperparathyroidism causing lytic lesions. So that will cause osteitis fibrosis cystica, that is renal osteodystrophy, and then osteomalacia. Because of decreased vitamin D, the mineralization of the bone does not happen. Osteoporosis in chronic kidney disease is because of acid-base balance is not being maintained. So because of that, there is some abnormality in the hydrogen ion buffering. So because of that, the bone is having a problem related to that, causing osteoporosis or weakened bones. Okay, hypertension, congestive heart failure, and accelerated atherosclerosis. You know that the chronic kidney disease, the hypertension is maintained by the renin-angiotensin system, right? Whenever there is a chronic kidney disease or a broad diseases going into a chronic renal failure, they cause abnormality of the functioning of the renin-angiotensin pathway. So that imbalance will cause hypertension of the patient. Okay, then accelerated atherosclerosis. Then uremic frost. This urea will get deposited in the skin and this will result in the uremic frost. So this is about the renal failure that is happening because of different diseases and causing different clinical findings. So what are the lab findings in this? Electrolyte imbalance, obviously there can be hypokalemia, hypokalemia. Then acid-base imbalance can cause metabolic acidosis. Normocytic anormochromic anemia, because the RBC production itself is low, it is not related to hemoglobinization. Then increased serum cystatin C, usually cysteine protease inhibitor, is produced by all nucleated cells. Okay, so whenever there is more than 1.3 milligrams per deciliter cystatin C, then we can know that there is some renal abnormality that has occurred. Fixed specific gravity, because there is abnormal glomerular filtration and tubular reabsorption and secretion. There is imbalance regarding the electrolytes that is happening in the body. So because of that, the specific gravity is usually fixed. In chronic kidney disease, the fixed specific gravity is usually 1.010. Okay. Then there can be maxi and broad CAS because of the injury that is happening, and the epithelial cells and the CAS of the lipid and all, they get secreted and they form the maxi and the broad CAS. It can be seen in the urine microscopic examination. These are the lab findings. So what do you find in the gross? I told you it's same as the chronic glomerular nephritis. The shrunken kidneys will be there. So the renal function or the functioning renal mass is getting reduced. Obliteration of glomeruli, atherosclerosis or arteriosclerosis will be present. And then you can see that there is installation of proteins that can be seen in form of hyalinization or CAS. And the tubules will have CAS. So this is about the chronic glomerular injury and chronic renal failure and their laboratory and clinical findings. So today's class, just remember I talked only about the tubules and the interstitium. The tubules, that is the acute tubular necrosis caused by ischemic, and the toxic forms, the acute tubular injury caused by, that is acute renal failure caused by the thing, and then acute pyelonephritis, chronic pyelonephritis, drug induced, analgesic induced, the myeloma kidney, and what you call the urate nephropathy, and all these things eventually leading to the chronic renal failure, the chronic kidney disease. Okay, so in the next class, I'll be talking about the vascular abnormalities and the cystic diseases related to the kidney. I hope you are listening to my class, right? So thank you for your patient listening. I'll be ending the class.